You've heard a talk from Aubrey on issues that have concerned both him and I over the last 10 or 20 years and caused grief to us both. And you're probably, if you don't work clinically, awfully happy that you're not exposed to the kinds of things that he's been exposed to. You haven't been asked to do the kinds of things that he's been asked to do, like put his name to ghostwritten articles. It may be a little bit inconvenient for all of you who have to write your own articles to know that most of the doctors that you're competing with in RAEs and things like that have 80 to 100% of their articles ghostwritten for them. But that's not what I'm going to talk to you about. What I'm going to talk to you about is the role that people here in this room play in hiding the truth for people who are on various different drugs. The statistical techniques that you guys know all about. You'll have been there, I hope, saying, well, look, this is awful stuff about articles that's been ghostwritten and lack of access to data, but ultimately we have statistics and we've got controlled trials, and if we have methods like these, we can control the awful things that the industry do. I'm going to try and say to you that actually the approaches that you take function a bit like this. They're industry's ultimate way to hide the bodies. The tables you see here are exactly the same size and shape. They don't look like that to you, but the slides will actually be available, and if you want to print off this slide and see if you can map the table on the left onto the one on the right, you'll find that you can. And the role an awful lot of you in this room play is to create an illusion like this for journals, for the public, and others. Having said people in the room like you, I mean people who do the kinds of jobs that you do. I'm hoping that the people in the room here, actually, your hearts are in a different place, and you're going to try and help me try and turn things around slightly. I'm confused about how to move forward here, and I'm hoping that you're going to be able to help me come up with some better ideas, or things that we need. And you will all, I'm sure, know the kinds of tricks that the industry get up to in articles that have been published. There are tricks like this, that they change the endpoints that are used. You don't get to see the protocols for the trials. They use surrogate outcomes and things like that. They use concepts like numbers needed to treat, which are completely inappropriate in about 90% of the cases. They talk about relative risk rather than absolute risk. You'll know all of this. I've listed the tricks recently on a blog I've got, davidhealy.org. What I'd love you to do is to go into the blog, add to the tricks that are there, name the tricks. If we're going to get people to understand what's going on, we have to have catchy names for all these tricks. And what will be awfully helpful is I can give you instances of all these tricks in the mental health field, but what I need is people who can give me instances of the same kinds of tricks happening elsewhere in the rest of medicine. But I'm going to take you on now beyond the usual things that you can see in loads of books. Lists like that are the usual things that you can see in loads of books, to things like this which you don't see so often but won't come as a huge surprise to you. These are the suicidal acts that happened in the clinical trials that brought these three antidepressants to the market. The trial, there was a very large proportion of the suicidal acts happened in the washout phase of the trials. What you find, though, in all of the published articles, in part because these articles are written by ghostwriters, in part because they're written by company personnel, you find that actually the suicidal acts appear like this in the published articles. That you have the washout acts put under the heading of placebo, because, well, these patients weren't on anything during the washout period, which is the same as being on placebo, isn't it? So why don't we just put them under the heading of placebo? You have acts like this one down here, where in a GlaxoSmithKline trial, after the active phase of the trial was over, this patient who had been in the placebo arm of the trial was put on Prozac and 10 days later went on to commit suicide, and he's regarded as a placebo suicide. So all of the maneuvers you see there have happened in the course of these trials. In fact, in the published literature, you can't find the real distribution of the acts at all. Even when the companies did this, you find that there's an excess of suicidal acts on active treatment compared to the placebo group. Now, that kind of trick won't, well, let me go back actually before I end with that slide. As you see over there on the left, you'll see that I've indicated that the companies, it's not just these 3 antidepressants in which this kind of maneuver has happened. It's drugs like Vioxx that you've heard about. It's drugs like Vandia. It's almost any of the best-selling drugs in medicine. Companies literally hide dead bodies in order to make their drug look not so bad. That sounds awful to you, but I'm going to show you a lot worse. Take this trial, which was a Prozac trial, which happened here in London. The lead clinical investigator for the trial was approached by the company to run a trial of Prozac in what was called recurrent brief depressive disorders. This is a group of mostly young women who regularly go on to cut their wrists or take overdoses. And it was a group that was reasonable enough to do a trial in to see if this drug helped. The trial was done and terminated. What you can't find from the published paper, which didn't get published until 5 years later and possibly got published for an extremely interesting reason, which I won't go into, you don't find that in this trial, placebo was statistically significantly superior to placebo. Sorry, placebo was statistically significantly superior to Prozac at the 0.0001 level. Okay? If you're going to treat this group of patients with an SSRI, you do not have any basis from this trial to do so. In fact, you've got very strong indications that this is a bad drug for this group of patients. So, given that report comes out, why would GlaxoSmithKline, who produced another SSRI, go back to the same investigator and using almost exactly the same patients, ask him to run a trial of their drug compared to placebo, producing the results that you see here, which is a 3-fold increase in the rate of patients with the condition going on to a suicidal act on the active drug compared to the placebo. You won't find these data anywhere because they've never been published. But why did GSK go back and ask for a rerun? And why then, having produced data like this, did they go back for a further run at this issue, taking the drug to a slightly different group and producing this article that you see here, which is again giving their drug compared to placebo to a group of patients who've got recurrent brief depressive disorders and getting much the same outcomes as you've seen before. Well, here's the reason that they did it. It's a neat little trick, and it's this. A few years later, GSK, well, I would say they knew from a long time beforehand, as you'll see, that there would be a point in time when the data on their antidepressant causing people to go on to commit suicide or to go on to a suicidal act were going to become statistically significant. And that happened for them in 2006. And here's the data from a GSK publication, which shows a relative risk of a 6-fold increase on their drug compared to placebo in patients who got major depressive disorder. And there's the actual data there at the bottom. But if you add in the 3 trials that you've seen previously in which, well, if you add in the 2 trials in which their drug did worse than placebo, what you get is a curious outcome, which is this, that paroxetine, which caused an extra 30 suicidal acts in about 167 patients who were from this recurrent brief depressive disorder compared with placebo also causing about the same number of acts in this group of patients. If you add those into the mix, all of a sudden the data looks extraordinarily different. Actually, paroxetine is a drug which appears to prevent suicidal acts. That's an easy trick that any advisor to any pharmaceutical company could have told them about. Ethics committees asked to give a view of, is it ethical to do a drug trial like this in a group of patients like this, would have looked at the protocol for the trial and said, well, look, it seems reasonable. They've got a reasonable protocol. They're going to give this drug and they're going to compare it to placebo in a group of patients who do need to be helped. What could be wrong with this? The ethics committees are most unlikely, and in fact the statisticians who may be on the ethics committee are most unlikely to recognize the true purpose of the trial, which was to hide a problem that the company knew their drug caused by producing more events of this type. Now, something like that I'm sure happens in most branches of medicine. If you haven't fully understood what I've said, we can go back over it later. But I'm sure it happens in most branches of medicine. You can do just the same kind of thing. And those of you who know of instances of this happening in the asthma area or heart attack area or whatever, I'd be very keen to hear about the instances. This is all up on the blog if you want to look at it in more detail later. But, okay, things like that look awful, but actually, it's statistics, really, that help companies to hide dead bodies, not tricks like the ones you've just seen, which are fairly awful and gross. It's things like this. Take drug A, which may be an awfully useful drug for a particular problem, but causes a small proportion of people in the trial to drop dead from a heart attack or whatever. The data we have from the trial, our combination of trials, shows that there's a twofold relative risk of getting a heart attack on this drug compared to placebo. The data is statistically significant. Now, take drug B, which may be a treatment for the same illness, but has, as you'll see here, a fourfold higher rate of people dropping dead from a heart attack in the trial or group of trials that it was put into, but the data is not statistically significant. Well, the company argument here is because the data is not statistically significant, that actually drug B is causing no heart attacks at all. Okay? If you're advising treating your husband or wife or children with this drug, you would say the dangerous drug to take is drug B. What the industry, supported by the BMJ and JAMA, because of the levels of statistical expertise in these journals, are saying to you is that the dangerous drug to take is drug A. Drug B comes with no risk at all. The fact that there's a chance that the data isn't a fourfold increase on drug B compared to drug A isn't the way the argument's pitched. It's pitched as, because the data is not statistically significant, there is in fact no risk on drug B. And insofar as any of you deal with these issues and don't get the message out that this message is wrong, you're party to an awful lot more people dying than die from the previous two tricks that you've seen. Let me show you a very good instance of just this. When reports came out first of people becoming suicidal on Prozac, the response from the company was this article in the BMJ, saying there are anecdotes on the one hand that our drug causes people to become suicidal. Here are the controlled trials, all of them. And when we put the data together, it's clear that there is no risk on Prozac compared to placebo. Well, if you take the data that you've just seen there and map it out, here's what it looks like. There's a 1.9 or 2.3-fold increase in risk on Prozac compared to placebo. What the company write in the article, which everybody in this room can agree with, is this, that these data show that the increase in risk is not statistically significant. We can all agree with that. What you shouldn't agree with, and it will be interesting to see if anyone in this room agrees with the next statement in the BMJ. The BMJ, by the way, is read by 100,000 people, most of whom have no links to the pharmaceutical industry, few of whom have any conflicts of interest. They're not paid by industry to hold the views that they have. They may be even hostile to industry, but no one objects, no one writes in and objects to the next statement in the BMJ article, which appears all over the place in medical journals generally, which is, the conclusion is that data from these trials do not show that fluoxetine is associated with an increased risk. A 12-year-old could have told the BMJ that there is a doubling of risk here. No one wrote into the BMJ to say, hey, wait a minute here, there's a doubling of risk. The onus should have been on the company here to prove their drug was safe, rather than the onus being on all the rest of us to try and say, well, in actual fact, there is an increase in risk here. There are a few other things that those of you who are interested in these kind of things may be interested in to do with the article you've just seen, which is that the company introduced a further maneuver here, which was a maneuver that took advantage of a move that there had been back then, which was to say we shouldn't just look at the number of adverse events that happened in proportion to the number of people who were in clinical trials. We should control for the duration of exposure to treatment. And this allowed the company making Prozac to argue that Prozac was safe when you control for the duration of exposure to the drug. If the drug causes a problem during the first few weeks when you go on it, what you do in your trials is to keep a bunch of people who've been doing awfully well on the drug on it for years, and you include them in the data you hand over to the regulator. And by this means, you produce an argument which says that space shuttles are actually the safest form of travel. That if you take into account the fact that actually the space shuttle orbits the Earth millions of times and clocks up hundreds of thousands of miles, and there's very few crashes and very few deaths per mile, well, space shuttles are awfully safe. And that's the argument that the company uses, and risks being used by any company appealing to controlling for duration of exposure. Let me skip the third trick that was there at the bottom. Okay, so I've shown you some awful things that industry does. I've shown you some manipulations of statistical techniques that many of you here in this room, I hope, would think are just bad practice. They're not the kinds of things that you would do, but it'll be interesting to see. Maybe there'll be an argument on this point. But you're still there saying, well, we've got a few ramparts we can hide behind. We have ultimately, at the end of the day, got control trials. And these are the gold standard. And provided we have control trials, we can control industry. Well, this is where the ultimate illusion comes from, the ultimate contribution to these two tables looking different when in fact they're exactly the same size. Control trials are a company's best way to hide the bodies. And how they do it is to make sure that the control trials are done in patients who have a condition, a disease. As you see from the company here, they're saying when the issue blows up about Prozac causing people to become suicidal, the key message for the company to get out is it's the disease, not the drug. And how that plays is this. Again, what you've got here is a group of control trials done where we've looked at the suicidal acts that happen on the active drug versus the suicidal acts that happen on placebo. As you see in this instance, however, what we've got is a lot more of the patients taking placebo going on actually to a suicidal act than you saw in the previous slides. How do we do this? Well, once you understand in just what's actually happening in the case of patients who go on actually to a suicidal act, you can see how to do it, which is this. In the case of the trials of the SSRI group of drugs, these are extraordinarily weak drugs, and because of this, they were put into trials of patients who were mildly ill. Because of that, the patients in the placebo arm of the trial were at minimal or no risk of going on to any kind of suicidal act. If you were to take a stronger drug, like the older antidepressants, and to put them into a trial of patients who are more severely ill and at greater risk of going on to a suicidal act, and the drug helped them, you could conceivably produce an outcome like this, which is that in the placebo arm of the trial, there would be more patients going on to a suicidal act than there is in the active treatment arm. You might conclude from data like this that it shows that controlled trials show that antidepressants don't cause patients to go on to commit suicide or go on actually to a suicidal act. You would be wrong. It's a simple maneuver that we can do in the case of people who are suicidal. Based on what we know about what the drugs are doing and what the illness are doing, we can manipulate the trial to get data that looks like this. A controlled trial, in principle, cannot show whether a drug causes an adverse event or not. We can do it when we know just what the problem is. We can maneuver things around so that the controlled trial ultimately does it. But in the case of adverse events caused by drugs where we don't know quite what's going on in the way we do here, how do any of you know whether the data that's coming out from the controlled trials has revealed or hidden the problem? Hopefully that's clear enough. I've been working on these issues and I'm not sure I've got them absolutely clear myself just yet. Let me give you a slightly different way to look at these issues. This is not an anti-controlled trial talk. It's just trying to point out to you the problems we've ended up in. We can use controlled trials to bring the hazards out. We can use controlled trials to bring out something like this, which is the kind of scenario where all of the suicidal acts will be over in the active treatment arm rather than in the placebo arm. How would we do this? Well, we'd do an RCT of a drug. We do a drug trial. Isn't that what we do the whole time? No, it's not. We rarely do drug trials. The BMJ and the Lancet and JAMA never publish drug trials. Have I gone mad? Well, no. This is a phase 1 healthy volunteer trial. If you want to see the effects of the drug, you give it to healthy volunteers. If you want to see the poisoning, you give it to healthy volunteers. If you want to hide the poisoning, you do a trial in a group of patients who have got cardiac problems or asthma problems or depression problems because they've got a bunch of symptoms, and you can attribute whatever's happening to the illness rather than the drug. Companies do phase 1 trials, but they never publish them. We now have a register of clinical trials for disease indications. We don't have any register of clinical trials or controlled trials done in healthy volunteers. These are among the most corrupt and fraudulent in all of medicine. You know that in the case of clinical trials, that we often recruit the patients to these through adverts, that the patients don't always exist, that the investigators have ended up in jail. But clinical trials are a reasonably patent, transparent exercise compared to the healthy volunteer trials that happen. In Leeds in 1983, 7 or 8 years before sertraline, one of the SSRIs, came on the market, and the company launched into arguing that their drug does not cause people to become suicidal, they ran a healthy volunteer trial. 6 women on sertraline were being compared to 6 women taking placebo. They ended the trial after a week. Every single woman taking sertraline and one of the women taking placebo dropped out because they became apprehensive and agitated. Their diaries pointed to things like they were becoming scared of the thoughts they were having. The company report on this was, it's absolutely clear our drug has caused this problem. This here, long before the drugs come on the market, was convincing evidence that the drug caused people to become suicidal. All of the problems that we have later. It only took 12 volunteers. I said one of the volunteers was taking placebo. Well, in actual fact, the placebo volunteer who became suicidal had sertraline in her blood as well, so the results were even more convincing. Evidence-based medicine. There's the word evidence in French means something totally different to what it means in English. Evidence in French means it's evident. Evidence in English means it's proven. In French evidence-based medicine, you do things that are obvious and evident. If you're going to jump out of a plane, you take a parachute. That's evident. In English, the companies have done or could do controlled trials of nicotine, Valium, methylphenidate, and could do alcohol as well in exactly the same protocols that brought the SSRI trials onto the market, where they've only got to have 2 positive trials out of 50 to 60 trials, where they can suppress the data, ghostwrite the results, switch the endpoints, and you could have shown that all of these drugs were as effective as SSRIs for people who are depressed or anxious. It would be proven, as opposed to being evident, that you should take drugs like these for nervous conditions. On the basis of the kind of evidence that we produce, we've almost made it public policy to give drugs like these to patients who've got nervous problems in primary care. As the ultimate symbol of all this, we brought controlled trials in to help enhance the safety of the treatments that we give patients. The argument was, if we can show that the treatment works, then at least we're going to improve safety. If the treatments don't work, well, it doesn't make any sense to take the risks that these treatments may pose. Controlled trials were brought in because they're a wonderful method to show when treatments don't work. What we've been able to do is turn them around so that they've become wonderful ways to promote drugs that barely work at all on the basis of controlled trial data of minimal efficacy. Not that the data shows that the drugs are actually effective, but that there's a signal of efficacy based on something like rating scales, for instance. As a good symbol of where we've gone wrong, the thalidomide, as of 1962, when controlled trials were brought into the regulatory process, was the only drug that had gone through a placebo-controlled trial before being brought onto the market. A placebo-controlled trial in which it was shown to be efficacious and safe. The method we brought in to stop problems like this happening again, well, it was the only drug that had been through that process at that point in time. We now have a world in which 15% of pregnant women in the UK are being put on antidepressants during pregnancy, despite evidence that they double the rate of birth defects, double the rate of miscarriages, and probably double the rate of learning disabilities in the children born to women who are on these drugs during the course of pregnancy. We're in a world where we've moved from 50 years ago, cars didn't have seatbelts or airbags. Now your car, if it's a BMW, won't start if you haven't got the seatbelt in. You don't just have this kind of symbol. A world in which 50 years ago there was a symbol like the poison symbol on pills. They've been removed. The industry have insisted on symbols like this being removed. Instead, we've got proposals that drugs like the antidepressants come stamped with a symbol like this to reassure pregnant women that it's a good idea to have these drugs during pregnancy. That if you don't, the illness you've got, the nervous condition you have will cause your child to have birth defects, when all the evidence is that the drug, whatever the evidence is that any of your nervous conditions could cause this, that the drug you're going to be put on is likely to double that risk. So at the end of the abstract, I've outlined two things that I think, well, I'd be keen to get all of you to help me solve, one of which is this. We used to think that drugs were poisons. It's no harm to have poisons. It's no harm to give a poison to people. The art of medicine is all about trying to get the dose of the poison right and to balance the risks of the poison against the risks from a severe illness. We have an image instead, which is that the drugs are risk-free. All of the risks lie in the illness, and it's the duty of doctors just to make sure that everybody who has any conceivable form of the illness, mild or severe, needs to be put on treatments. We need to produce a different metric which brings back either the poison element into it or a better appreciation of risk-benefit ratios. We also need a metric like this, which is that doctors well, there's no drug we have in medicine these days that has ever been discovered through controlled trials. It's always been discovered by doctors making observations for the most part. Most of the adverse events of drugs aren't discovered in controlled trials. None of them are discovered in controlled trials. They're all discovered by doctors reporting the evidence of their own eyes when it's evident. They're even discovered by hairdressers reporting the obvious effects of drugs, such as when they're doing the hair of women who are on oral contraceptives. They're able to say, hey, your hair has changed. That's how we make progress in this area. It's how we still are most likely to discover new drugs. So again, this is not an anti-industry talk, but we need a metric. If one person reports a person becoming suicidal on an antidepressant, you're not going to believe it. If 1,000 people report this happening, you are going to believe it. Is there a way to work out when we cross a credibility threshold, not that the drug is actually causing the problem, but that these observations can be believed? That's the kind of metric I think we need in the current moment. So what I think I've been talking about is this. We've got a world in which on the one side you've got controlled trials, and they're spun as being objective. They offer certainty. On the opposite side you've got clinical observations, and they're highly subjective and they're uncertain. You can reframe all this. The controlled trials, as done by industry in particular, are mechanical exercises in which people go on autopilot, and the observations of doctors and others, like hairdressers, may be much more thoughtful and professional. If the risks all lie, or if there are risks with treatment, and if the companies are able to persuade you that the drugs are risk-free and things go wrong, then the risks must lie with the doctors. So I think it's in the professional interests of doctors to get to grips with all of these. And here are the final points that I'll leave you with. RCTs are much less of a gold standard than they're typically portrayed as. I think claiming that they're a gold standard is a rhetorical device that suits industry. They don't demonstrate cause and effect ever. They shouldn't ever replace good evidence, and significance testing should be all about the credibility of observations rather than anything else. So hopefully this will play into the interests of this group here and provoke some debate. Thank you.